Good morning, everybody. I want to thank the moderators for the invitation to participate in this session. I have no disclosures. There's a fair amount to get through in just under 10 minutes, so we'll just jump in. So I'll review the incidence of implications of hemorrhagic complications after bariatric surgery, talk about a couple of example cases real quickly, and discuss management strategies. I think the incidence of hemorrhagic complications after bariatric surgery is actually unknown, but the literature suggests that it's somewhere between 0.4 to 6% if you're considering the two most common operations we do in bariatric surgery. And of course, as might be predicted, presentation varies pretty widely from acute and life-threatening to more chronic and subtle. What you encounter in the literature for risk factors include hypertension, prior surgery, early experience, and not using a staple line reinforcement, particularly in the context of a sleeve. So case scenario number one is that of a 45-year-old woman, BMI 40, has a history of hypertension, no prior surgery, undergoes a sleeve gastrectomy. In pre-op, got 40 milligrams of enoxaparin, that's what we do in my institution. Case lasted about 40 minutes, has a staple line reinforcement was used, blood loss was minimal. About 6 hours postoperatively, becomes hypotensive, BP 80/40, she's tachycardic, the rest of the vitals, as you can see there. First intervention, she gets a liter bolus, normal saline, which brings the blood pressure up somewhat. She's still tachycardic, however. A CBC was obtained that shows a hemoglobin of 8, had been 12 pre-op, platelet count and coags were normal. How many have heard enough and would take this patient back to surgery? All right, well, so blood pressure hangs around 90 for an hour or so. So a couple of units were ordered, and she gets a unit, but by the time 2 hours comes, the second one started. The patient's, however, complaining of worsening pain. She's pale, she's diaphoretic. Blood pressure's back down to 80, 130s. Definitely she goes back to the OR, right? So upon laparoscopy, intra-abdominal blood was encountered. About 800 cc's of blood clot was evacuated. There was no active bleeding that was actually noted. Some generalized staple line ooze. The surgeon places a few clips to make himself feel better. Patient gets a unit intraoperatively. She completely stabilizes during the operation. She was extubated, returned to the floor, and the remainder of her course was unremarkable. Case number two is that of a 35-year-old woman, BMI 50, and history of type 2 diabetes and sleep apnea, prior cholecystectomy. She takes a GLP-1 analog. She undergoes a Laparoon-Y gastric bypass, pretty standard 50-centimeter BP limb, 150-centimeter roux, fully stapled JJ and a linear stapled GJ. Again, that's how I do it. And the case lasted about 2 hours. Blood loss was minimal. About 12 hours post-op, she develops about 400 cc's of maroon-colored stool was collected. She wasn't having much pain, actually, but the patient was visibly anxious and concerned about what's going on. She is febrile, mildly tachycardic, blood pressure soft at 90/60, the rest of the vitals, as you can see. She gets a bolus. CBC was ordered, which shows a hemoglobin of 9, had been 13 pre-op. Coags and platelets were normal. The rest of the VT prophylaxis was held. How many would take this patient back to surgery? Yeah, so, after the bolus, the blood pressure sustained is elevated to about 120/60. Heart rate slows down. Another 6 hours later, she has 2 episodes of blood per rectum. 300 cc's total. Repeat hemoglobin at that time, though, was 7.8. So she gets a unit ordered, which brings up blood pressure to 130/70. Heart rate normalizes. Post-transfusion crit stabilizes. She has another episode, smaller, about 8 hours later. The repeat hemoglobin was stable, though, and the rest of the vitals were stable. This patient was not reoperated on, of course. She was watched. She has an otherwise unremarkable hospital course. Both of these cases were fabricated, of course. But if you've been around bariatric surgery long enough, you've seen this. And actually, a lot of the principles of gastrointestinal bleeding will apply to the remainder of this talk. But the point is, the cases were intended to highlight some of the complexities and frustrations that you can face when you engage with this problem, because even when you're doing the right thing and you take an unstable patient back to the operating room, it may be deeply unsatisfying to you. On the other hand, restraint can come along with some poetry and be valuable. So the reason we care about this, I think, is that we know that the patients who bleed after bariatric surgery actually have a much higher incidence of other morbidity. Any complication you can think of, from infectious and cardiopulmonary complications to mortality. And so we do well to think very carefully about our algorithm and be clearly, sort of clear-headed when we are faced with this issue. We'll talk about sleeve and gastric bypass. It's been done in the last two talks because they're the two most common operations we do, but also because there are parallels between them and the other operations that exist. And so staple lines bleed, of course, in sleeve gastrectomy, the omentum, short gastric vessels, the abdominal wall. Remember the abdominal wall. Patients can bleed a lot into the abdominal wall. Intraluminal bleeding is fairly uncommon after sleeve, but of course can happen. DeAngelis tried to look at this problem in a paper published about 4 years ago, and just under 900 patients over a 4-year period. The group routinely used drains, at least at the time. They had an overall bleeding rate of about 1.9%, about 17 patients, half of whom were managed operatively and the other half non-operatively. In the non-operative group, about 50% of them developed infected hematoma. And about half of that group developed late leaks. And so you might imagine that this is not a group that thought very favorably upon non-operative management of post-op bleeding. So their algorithm that they propose is the following. The diagnosis of bleeding is made. Patient is assessed rightly for hemodynamic instability. If they're unstable, they go to surgery. If they are stable, they get transfused and are reevaluated every couple hours. With continued stability, patient gets a CT scan. If there's active bleeding and/or collections, they go to surgery. If there's no active bleeding, they're closely observed. I think this is a fine algorithm, though some might have an issue with taking everybody back just because there's a collection. And I think some judgment and nuance is called for there. Moving on to gastric bypass, this is often categorized into early versus late bleeding with the arbitrary 30-day cutoff there. And of course, you have staple lines here as well that can bleed, but now you have mesenteric vessels from where the small bowel was divided and where the stomach was dissected, so branches of the left gastric, et cetera, can bleed and bleed a lot. Abdominal wall can bleed here, of course, as well. But perhaps a more useful distinction is extraluminal versus intraluminal bleeding, where the thinking, what happens in actuality is in addition to those signs of hypovolemia, you get hematemesis and hematochezia to tip one off. A particular scenario, I think, of intraluminal bleeding that everybody should be aware of and think about all the time is the jejunostomy that obstructs with a blood clot. This is, which is to say that if the patient should present with obstructive symptoms in addition to those changes in H&H and hemodynamics, such a patient should be imaged. And if you image them and see this is not a non-operative scenario, it's a latent catastrophe. So what you're seeing is blood and clot in the remnant with a dilated duodenum and BP limb because the JJ is obstructed. This usually requires operative intervention, opening up the JJ, getting the clot out, plus minus opening up the remnant and evacuating that. Some advocate for leaving a gastrostomy in the remnant for decompression, but this is a very important scenario to keep in mind. Moving on to late bleeding in gastric bypass, intraluminal bleeding for sure dominates here with GJ or marginal ulcer by far the most common etiology. This can present acutely, of course, with hematemesis, although there's often a history of melena for a couple of days or even a couple of weeks. Hematochezia would indicate that there's more rapid bleeding, but the key here, this rarely requires operation. Endoscopic management is the mainstay with acid suppressive therapy. Be aware of the posterior ulcer that erodes into a large vessel and bleeds. This can bleed massively and require surgical intervention. But of course, if the patient's stable and hemodynamics allow, then endoscopy, angiography, and embolization should be considered. Be also aware of the gastric membrane ulcer that bleeds. If you've looked everywhere and can't find a source, remember that there's a remnant that can ulcerate and bleed. The diagnostic complexity here has been overcome with things like pediatric colonoscopes, spiral enteroscopy, and lap-assisted placement of trocars into the remnant to interrogate the remnant. Finally, I'm running out of time, but this is a paper that, or have run out of time, is the, this paper is analogous to the sleeve paper, except a lot more patients, 4,500 patients, gastric bypass over a 10-year period with a bleeding rate of just under a percentage point. Early bleeding was much more common than late, as we've talked about. The majority of patients were managed non-operatively, and this rings true to experience. Early bleeding will require reoperation more commonly than late bleeding, and if there's a and we're reminded in this paper that a previously undiagnosed bleeding diathesis is sometimes encountered. Finally, so that group also share an algorithm that's fairly similar to the stable one to the sleeve one, with the unstable patient fairly directly marching toward the operating room and the stable patient allowing us to think and vacillate and do all the different things we do in surgery. And but the thing to point out here is that endoscopic and angiographic interventions I think have a greater role to play in gastric bypass bleeding than in sleeve bleeding. And so I'll summarize by saying that the overall the risk of hemorrhagic complications is low after bariatric surgery, but the sequelae are potentially grave. Everything from extended length of stay up to and including mortality is a risk in these patients. And recognizing things promptly with special attention to a few key scenarios or in early management are absolutely important to reducing the risk of failure to rescue in these patients. Thank you.